in the interest of time, we'll start off with PI-FAB Target and more imaging post-FT with Dr. Ghai.
Thank you, Tim. So I'm going to be speaking on MRI after focal therapy. A close surveillance of patients is needed after focal therapy, as we know, for detection of recurrence or to detect new focus of cancer. I think we all agree that the assessment tool should have a high negative predictive value for clinically significant cancer so that patients can avoid repeated biopsies during the subsequent surveillance. MRI is routinely used to evaluate the treated gland and has shown to be more reliable than PSA. But unlike PI-RADS and PI-RR, there is no standardized, universally accepted scoring system for MRI after focal therapy. PI-FAB and Target scoring systems have been proposed recently, and in the next few slides, I'm going to discuss both these scoring kind of systems that have come out. So PI-FAB, which came out of UCL in London, Francesco was the lead radiologist, is really a first step in standardization of MRI interpretation after focal therapy. It involves a 3-point scale for assessing the 3 MRI sequences in sequential order. So it's kind of a 3-tier kind of a scoring system. DCE is considered the most relevant, and then you assess the DWI, diffusion-weighted imaging, followed by T2-weighted imaging. And if you look at the kind of, descriptors, DCE, as they describe, is positive. It is focal and early at the site of the treatment or at the margins. A high B value in diffusion-weighted imaging is noted as a focal hyperintense signal. ADC map is not very reliable because of the difficulty in distinguishing between fibrosis and a general low signal because of tumors. So really no importance to ADC map. And then T2-weighted imaging is positive. It is focal hyperintense. So if you look at the schema that was proposed in PI-FAB, if the DCE is positive and DWI is also positive, it's a score of 3, highly suspicious. If DCE is positive but the DWI at that site is negative, it is an equivocal kind of a focus. It's a score of PI-FAB 2. However, PI-FAB does not, it does have rules to upgrade if the DCE is equifocal. So if DCE is more than 3 millimeters, you can kind of bump it to a score of 3. And I would think that most of the times when DCE is positive, it is larger than 3 millimeters. So again, if DCE is positive, it's most likely to be suspicious for cancer, irrespective of DWI. And if both DCE and DWI are negative, then it is negative. But I think what PI-FAB does not address is the scenario if diffusion-weighted imaging is positive, but DCE is negative. And is there truly an instance when you see that? And that may be one of the limitations of PI-FAB. Target subsequently kind of came out. It's an expert consensus approach to generate prelim guidance for MRI interpretation after focal therapy. It was initially a kind of a systematic review of articles was performed. 73 unique studies were included, but only 2 studies detailed individualized sequence-specific scores amongst those 73 studies. And I will mention one of those 2 studies were actually from our site, published about 3 years ago. So one could say that the Target recommendation is mostly an expert consensus document rather than based on evidence, and that's because there is not much evidence in literature around individualized kind of sequence-specific scores. So a list of 295 statements was drafted with a core group of experts in Target. 2-round consensus study was conducted. And the recommendation was that each sequence should be assessed from a scale to 1 to 3, non-suspicious, equivocal, or suspicious, respectively, and the overall score calculated on a 5-point scale, similar to PI-RADS and PI-RR. They recommended a 2-tier kind of an algorithm approach, DCE as the major sequence, again, overall suspicion of recurrence, primarily driven by DCE, DWI and T2-weighted imaging, both minor secondary sequences, and therefore influence the overall score to a much lesser degree. They, however, specifically mentioned that negative or non-suspicious DCE, so a score of 1 on DCE can never lead to a score of over 2 out of 5, even if diffusion-weighted imaging is suspicious. And if you look at the describers within the target scoring for DCE, a suspicious lesion, a score of 3, it has to be focal, it has to be early, and I think we all agree on that. It has to be strong, and it has to be nodular. And a score of 2, an equivocal, it again has to be focal, and it has to be early. It may not be strong, it may not be nodular, but it has to be focal, and it has to be early. And of course, a score of 1 if there is no early enhancement or there is late enhancement. When it comes to DWI, no consensus was achieved overall, but the suggestion was that, again, a 3-point score, 3 is suspicious. If it is moderate or intensely high on the high B value, equivocal if it's mildly elevated on the high B value, and non-suspicious if there is no elevated signal. And again, ADC map was not considered because, as we know, it is not very reliable. There's going to be black signal, dark signal because of fibrosis. And it's difficult to distinguish. And then the schema, again, if you have a score of a DCE score of 1, it can be bumped only up to a 2, but a score, DCE score of 2 is at least a score, overall score of 3. So here's an example of a tumor, a pre-treatment exam as a right peripheral zone, post-ablation appearance. DWI is totally negative, right? There's no focal area of restriction, but the DCE is positive, it's strong, early enhancement, focal, nodular, strong enhancement. And if you go by PI-FAB or by target, and this is more than 3 millimeters in size for sure, so even if DWI is negative, by PI-FAB it's a score of 3 out of 3, on target it's a score of 5 out of 5, on biopsy it was grade group 3. Here's another example. I don't have the pre-treatment image, but the focal area kind of after ablation, restricting, focal nodular, early, strong enhancement, quite straightforward on both the scoring systems. But I'm going to show you this example now. So on the top is where the lesion was. This was grade group 3 on targeted biopsy, post-ablation changes. And on the DCE sequence, I really do not see any site of early focal enhancement or stronger enhancement than at any other site in the prostate. Look at diffusion-weighted image. And quite clearly, there are 2 different foci, one in the medial margin and the other at the lateral margin. If you go by PI-FAB and target, you would not have biopsied this lesion, but this was grade group 4 on biopsy, cribriform positive, small focus. It was grade group 3 at the start before treatment. Another example, this is a lesion in the left kind of peripheral zone, shows restriction, DCE positive. And then on the post-treatment scan, again, I'm not sure if I see a definite positive. There's a little bit of enhancement on both the sides of the ablation. It's kind of linear, it's kind of homogeneous. There's no strong enhancement. And on DWI, there is a focus of restriction along the left lateral margin of this ablation. And you go one sequence up, you can again see that here. And this was grade group 2 on biopsy. So again, highlighting DCE is important sequence, but it's not the whole truth. I'll show you another example here. This is a study who was in my kind of trial, MRGFUS, treated in 2019. We do a biopsy and an MRI at 6 months and then at 2 years. His PSA had come down. But if you look at his DCE image here at 2 years, there is again no focus of early enhancement. There was one area that kind of catches your eye a bit, only because I wanted to stop it at a particular site so that I can. So that was the median lobe, but if I kind of, anyways, I'll probably point out to it as it comes across. There's a small area of enhancement. It's not strong, it's not kind of, but you kind of wonder, why is that enhancement coming up within or the anterior margin of the ablation? And of course, you look at DWI, it's a slam dunk. You know that that is tumor. And we did a biopsy. Another example, this was grade group 3, a large lesion. Patient did not want whole gland treatment, was taken to MRI-guided laser treatment. 1 year after his treatment, you can appreciate that, again, on the DCE, I cannot see any site of tumor, in this patient at the 1-year kind of mandatory MRI, but quite obviously, you see a tumor here. The image is not showing up well, but there was an area of restricted diffusion at the interior aspect, which was grade group 2, 25% for pattern. Patient went to repeat focal therapy. So based on our experience, we've come up with a kind of internal, for lack of name, we're just calling it a Toronto MRI score as of now. I'm running out of time, so I'm not going to discuss too much, but I will say that we kind of have a separate scoring for both PZ and transition zone, because I think DWI becomes more important in the transition zone. And then somewhat similar to the target, but it does have kind of a different schema. We sat down with the statistician to kind of see what is going to be the most sensitive and provide a good negative predictive value. Initial kind of a small cohort study, we did find that we had a high sensitivity and negative predictive value for TZ lesions, but again, there's going to be some inherent bias because we're assessing our own score compared to the others previously described scores and a very small cohort. So to summarize, I think MRI can be effectively utilized to monitor for residual or recurrent disease, but I'm not sure we are there as yet. PI-FAB and Target both provide great value and serve as the first step in standardization, and with further refinements as highlighted in our internal score, the accuracy can be further improved, and until then, I think we might need to perform biopsies. Thank you.